Welcome everyone to Alumni Reunion 2021. So excited to have you here in person this year and a few of our friends via Zoom. I'm Sarah Almacian, Associate Director of Alumni Engagement and Participation here at the college. I'm thrilled to be able to welcome you all to this lovely day. I do have a few housekeeping notes for our friends that are joining virtually. Today's session will be recorded. Our mics for all participants will be muted. Feel free to turn your video on or off as you feel comfortable. Feel free to use the reaction buttons when you feel inclined to do so. You can chat with one another on Zoom, and you can also submit your questions for our panelists by chatting to everyone. That way we can field those questions. So let's see. Yeah, that's about it. At the end of this, at the end of our first portion of the panel, we will open it up to audience Q&A. So those on Zoom, please submit your questions via the chat function. So let's get on with the program. I'm pleased to welcome this morning our new Dean of UIC College of Nursing, Dr. Eileen Collins.
So good morning, everyone. I can't tell you how thrilled I am to be here and welcome you, alumni, students, faculty, staff, and guests to our college reunion for 2021. I really just want to tell you how delighted I am to be here as the next dean. When I became the dean last month, I knew that I'd be called upon to represent the college in a number of different types of events, and I'm just really thrilled that this one is one of the first ones that I'm here to represent the college at, because with all of you here, this is just a lovely day and a lovely event. Having been here for nearly 20 years, the college's tripartite mission is to advance nursing education, research, and practice. And all of these things are really familiar to me, and I care about all of them deeply. Where I've had less exposure is here amongst all of you. The alumni who are really the living evidence of the excellence that we strive to achieve every day. So not only do I look forward to getting to know you, but our entire community as an engaged alumni, but I'm eager for the opportunity to introduce myself to you and to demonstrate my sincere intention to be a really great steward of your beloved alma mater. So this is why, for those of you that are here in person, I hope that those of you who are here in person will stay for our afternoon reception so we can start to get to know each other a little bit better. I know we've chatted this morning a little bit. We're going to be meeting at 2 o'clock in the Arthrington Mall right outside of the college at 2 p.m. And for those of you who are here virtually, I look forward to meeting you in person in the future. So let's start first with this morning. On our panel this morning, we'll hear from 3 remarkably accomplished alumni leaders, Dr. Maryann Alexander, Dr. Yolanda Coleman, and Ms. Jennifer Junis. In addition, we're fortunate to have a guest moderator who has been a leader in our UIC community for a very long time. Sabina Dombrowskis is an alumna. Did I get it? Is an alumna with and a former faculty member and a steadfast volunteer and donor. She's also a longtime member and past president of our college alumni board. So please welcome Sabina Dombrowskis to the microphone.
Okay. Thank you, Dean Collins. And you got my name right. I know it's quite a mouthful. So good morning, everybody. I'm so happy to be here. I think I've been at every alumni event that we've had. I am a proud alumna of the College of Nursing, and this is a real treat for me to be able to introduce and hear these tremendous nurse leaders here today. So why don't we start with first Dr. Maryann Alexander. If you want to make your way to the seat here. She's the Chief Officer of Nursing Regulation for the National Council of State Boards of Nursing. where she oversees all programs, policies, research, and legislative activities related to nursing regulation. She's a fellow in the American Academy of Nursing, also editor-in-chief of the Journal of Nursing Regulation. Prior to her role at NCSBN, Maryann was the nursing coordinator for the state of Illinois and the Illinois Department of Professional and Financial Regulation. She has worked as an advanced practice nurse and assistant professor at Rush here in Chicago before earning her PhD from UIC. Welcome, Maryann. Next is Dr. Yolanda Coleman, who is a certified nurse executive and a member of the American College of Healthcare Executives, who currently serves as Vice President of Patient Care Services and Chief Nursing Officer at Cancer Treatment Centers of America. Prior to that, she held leadership roles at Sinai Healthcare and St. Anthony Hospital and is an assistant professor of nursing at Oak Point University, which was formerly Resurrection. Yolanda is a published researcher, business strategist, consultant, and community advocate. She earned her PhD here at UIC and is currently the new president of the UIC College of Nursing Alumni Board. Welcome, Yolanda. And lastly on our panel is Jennifer Junis, who joins us from Peoria, where she serves as Senior Vice President of OSF OnCall, the digital care platform of OSF Healthcare. In that role, she is responsible for all digital experiences and on-demand services. Wow, that's a new role. Prior to that, Jennifer helped to lead 2 independent critical access hospitals in the OSF healthcare system, serving as president of OSF Healthcare St. Mary Medical Center in Galesburg, Illinois, and as a chief nursing officer at OSF St. Luke Medical Center in Kewanee, Illinois. She holds both a bachelor's and a master's in nursing administration from our college. Welcome, Jennifer. Thank you. So,
Sorry, I'm going to switch our camera so that our Zoom friends can see our panelists. So, all right.
All right. So let's get to it. The first question addresses sort of the elephant in the room. What does healthcare look like in this pandemic landscape? Yolanda, can we start with you?
Oh. Can you hear me?
Yeah.
So healthcare is ever changing. And of course, in the last 2 years or so with the pandemic, we've had to look at how we operate differently. Some of the things that we need to look at as we move forward in healthcare is looking at innovation and technology. We need to ensure that we have access to innovative ideas, not just in nursing, but in healthcare throughout. Access to things like telehealth and educating our health providers on telehealth and online learning. We also need to increase the infrastructure of nursing education to ensure that we decrease the gap of experience in nurses by having residencies and also fellowships to help support the education of our nurses. We also need to ensure that we have our advanced practice providers practicing at the full scope of practice to help ensure more access to healthcare providers for patients and families and communities.
Jennifer, do you have anything else to add to that?
Sure, I can add a few things. So the pandemic has really been fascinating and devastating all at the same time. What I've seen in the last 2 years in this role, which as you heard is relatively a new role. I've been in the role of Senior Vice President of OSF OnCall, which is really our digital health entity that has been formed within a traditional health system like OSF Healthcare. So it's really built to scale digital care, and nursing is such a key component of that. And during the pandemic, we really realized that. We realized the things that we can do from a scale perspective when we really have nursing working at the top of their license in a clinical team that's centralized, that can remote patient monitor in a decentralized way, all the way from home remote patient monitoring in the home to intensive care in the four walls of a hospital, and how we could really be a part of the care delivery model.
Thank you. Okay, now Maryann, this is a question for you. Oh, I'm sorry. How has the pandemic shaped nursing education, the workforce, and licensure? Wow, that's a big topic.
Thank you, and I will try and be brief in answering it. First of all, I have to say, I don't know that we will really know the impact of this pandemic for a while to come, because number one, it's not over yet. But number two, a lot of the studies that are taking place are not completed. NCSBN is probably doing the largest series of national studies that is examining the outcomes and impact of the pandemic. And one of the studies that we're doing is in nursing education. And we are following a cohort of students across the country. Over 50 schools are participating, and we are looking at their clinical experiences, their the program, whether they're online or in person, and we are looking at their ATI test scores, the outcomes on the Nclex, and we're going to be following them into practice to really determine what the impact of this pandemic had on those students. And hopefully we will learn a lot from that, and even about how we can overall, things that were positive, the changes that we can make to nursing education. One of the positive things that have come from the pandemic in terms of nursing education was, it started out terrible. We were getting calls from across the country of, hospitals closing their doors to students, and students, the schools didn't know what to do. Students, some of them were on the verge of graduating and couldn't complete their last clinical. And so a lot of waivers were made with students doing 100% simulation and schools substituting what they were calling virtual simulation. And I'm not quite sure it was true virtual. But one of the things that we did, and a lot of schools and hospitals did on their own, was a partnership. And we brought together the nursing leaders from the major nursing organizations across the country. And we said, how can there be a better collaboration between hospitals and nursing programs? And so a lot of schools and hospitals teamed up so that students were more than just students. They worked as support staff. And so instead of them being in the way or nurses not having the time to deal with them, faculty were there guiding them, and they were actually working on the floor more than just 4 or 8 hours a day. They were getting paid for that, and they were also getting clinical credit for it. And some of these partnerships have really lasted and have become a model for nursing education in the future. In terms of the workforce, I can tell you this, and what Yolanda said, there is a huge, huge exponential increase in telehealth use across this country. We did a study looking at nurse practitioners a few years ago, and we said, how many of you actually practice telehealth? The answer was 0. We repeated many of those same questions now in the midst of the pandemic, and the answer was 50% of them. So it has truly risen. And if you look at just the overall numbers of telehealth companies and how many patients are seen by telehealth, it has just hugely grown. On the negative side, this has taken a true impact on nursing staff. They are stressed, They are burnt out, and we are seeing, unfortunately, an increase in substance use among nursing. And that is something that we really have to be concerned about. Many people ask me about numbers because overall individual institutions are saying, are we losing nurses? Nurses seem to be leaving. Right now, if we look at the numbers nationally, while that may be the case on individual institution basis, we're not seeing that on a national basis. In fact, since 2019, the number of nurses, the trend for the nursing, especially RNs, has continued to grow. And even between January and now, there are about 100,000 more nurses in the workforce. And of course, that's the new grads. But we're doing a national nursing workforce study next year. We'll may be able to see some trends. And finally, I just want to tell you about licensure during the pandemic and then now. This is just a few things that were happening. It was chaotic. Governors were trying to help, but sometimes helping can create more chaos. And so nurses, they said, you can just come on over and work in our state without a state license. Well, if you were a compact state and nurses were coming in with a compact license, that was not a problem. But if you do that, if you say, come on in, you're a nurse, you could come and work in our state. What was happening was nurses that had revoked license, suspended license, were saying, oh, I'm a nurse, I can go work there. And people don't realize that the Nurse Licensure Compact has safety measures built into it. Those nurses are vetted. They need to meet 10 criteria in order to get a compact license. We know that is safe. So states need to join the Nurse Licensure Compact. They lifted collaborative practice agreements, a good thing, but some of those have waivers have gone away and they haven't been extended. Concerning Ohio and maybe one or two other states said, okay, new graduates, you can have a license, not a temporary license, but a license, regular license, without taking the Nclex. We'd like you to take it within the next year if you could. Well, you can imagine that many of them then were going and endorsing in other states, and there was chaos. And they also said retired nurses could enter the workforce. We're going to be doing a study and we're going to be looking at the outcomes of that. There has been, I think, one good thing in terms of licensure that has come out of all this is many states are realizing they need to join the Nurse Licensure Compact. And overall, I think we really are going to be learning a lot over the next year about how we better prepare should this happen again.
Okay, thank you. That's very interesting and informative. Well, Jennifer, what about, do you see some staffing challenges that your hospitals are facing? And while it seems like while nurses are maybe not as short-staffed as Maryann just alluded to, what are the challenges that you see?
Yeah, I think we are seeing a staffing crisis, not only in OSF, but also within the state and also within the nation. I don't think you can pick up anything that you're not reading about a staffing crisis in nursing, but also a staffing crisis just across our communities in many different roles. We've witnessed restaurant closures, we've witnessed service closures. We actually within OSF Healthcare have had some closures of services as well. Staffing crises. So there definitely is. One of the things that I see in my role in the digital health world is really how we can be impactful in that staffing crisis, how we can scale services to be able to have a ratio where we are supporting patients in a different, innovative way so that we can take those scarce resources of our nurses, our advanced practice providers, and be able to really impact more lives with less resources. So really taking the staffing crisis and starting to think about how we really change our care delivery models, to be honest. I think the pandemic forced us to do some of that in a very rapid fashion. And now going back and really looking at the outcomes and the lives we were able to impact out of necessity, out of a sense of urgency and crisis, but how we can continue that from a strategic standpoint to really continue to have those care delivery models move forward. A good example of that, I'll share a little bit of a story. During the pandemic, we were very fortunate to partner with the state of Illinois to take and look at some decentralized resources in local communities that are supported by centralized command center of a multidisciplinary clinical team. So being able to support over 700 zip codes for about 18 months of the pandemic to keep those in our communities who were experiencing COVID-19 symptoms. So think pre-testing, pre-vaccine, really a lot of knowledge about the COVID-19 virus. What we really did know was that it was highly contagious, and it didn't matter if you were symptomatic or asymptomatic. So those were things that we were trying to do to really help care for those who had symptoms, who thought they may have COVID-19, to be in that isolation in their homes so that they were not exposing our scarce resources within the hospital setting, the ambulatory setting, but really being able to monitor them, because we also knew that we were seeing decompensation from a respiratory standpoint when we had patients that were diagnosed with COVID-19. So able to deploy some remote patient monitoring into the home. Pulse oximetry was the key one, to be able to then also have that virtual visit and telehealth, and through texting, through phone calls, through virtual visits, to be able to really monitor them for 14 days so that they didn't leave their homes. That was supported by a command center of a team of nurses and advanced practice providers and providers that were able to care for over 10,000 patients across the state of Illinois. So thinking about how we do that now with chronic disease management, what impact could we make with hypertension, with COPD, with diabetes, if we take some of those same models of care of a community health worker that's digitally enabled, and pair that with remote patient monitoring from a centralized team.
Thank you. Yolanda, do you have any other additional thoughts on staffing challenges?
Sure. So it's been very challenging as a chief nursing officer here during the pandemic. One of the things that I've worked on, I'm in a magnet organization, and in a magnet organization that requires us to remain at 80% BSN and higher nurses. So I have been looking at that 20%, and I have collaborated with ADN schools of nurses to ensure that I can get those nurses in also to help with my workforce. One of the other challenges here in the state of Illinois that I have seen as a challenge for me as a leader is that I am not able to readily obtain travel nurses because of the issue with us not having a compact license. So I encourage all of you, whether you're a leader or a frontline nurse, to lobby. Lauren Underwood is a big supporter of us nurses here in Illinois. And we need to lobby with all of our senators and congressmen and women to ensure that we can get a compact nursing license here. So with me being challenged with staffing right now, I've had numerous issues with travel nurses. As you know, across the country right now, the travel nurses is pretty huge. Some of my CNO counterparts here in Illinois have faced tremendous turnover because their nurses are leaving at higher rates of pay to go travel across the country. So we need to become more concise and consistent in the nursing workforce and across the states and figure out how we can operationalize this so it works for all of us in each state. So again, I'm urging all of you to speak to your senators on this issue, because this has been a huge issue for me. No matter how high I increase the rate, it's just challenging because it takes so much longer for nurses to become licensed here in the state of Illinois. Even during the pandemic on the temporary license, it was still a challenge. And then the other thing is to collaborate. I live in both worlds as a professor and a leader in a hospital. And so I collaborate a lot with the leaders in colleges of nursing to ensure that I get the new graduate nurses or the MSN nurse practitioners that are coming out into the workforce quite readily. So that's another way to do that, to ensure we increase our nursing workforce. And I also sit on the ANA Nurse Education Expert Panel, and we're looking at other ways to include nurses and to strengthen a nurse force by providing and promoting education, not only for our new graduate nurses, but for our nurses that have been experiencing in the workforce for quite some time. So I think we have to be creative, think outside of the box, and also look at ways of doing things that we haven't done in the past. I know that there's an organization, one of our larger organizations here in the Illinois, Wisconsin area that are going to start using LPNs again. About 10 years ago, we took those LPNs off of the workforce and we took them out of the acute care setting. And so we're going to start looking at that again. How can they support our staffing workforce for our patient care also too? So those are some of the ways that we have to think a little bit outside of the box to help increase our nursing force.
Thank you. Very good. Maryann, what do all these challenges mean for faculty at academic institutions?
I think,
Yeah, you're on.
am I on?
Yeah.
Number one, I think the telehealth is here to stay. We need to have students that are prepared to work in that environment. We need to have students that learn how to be very flexible and resilient and work in different areas of the hospital when they're needed. And I also want to say that there is one thing that you need to know is we did a survey last year, a National Nursing Workforce Survey. 20% of the nursing workforce is planning on retiring in 5 years, and many faculty fall into that area. And that comes down to about 500,000 nurses total, obviously not all faculty, but that is something that schools need to be prepared for. And one thing I just want to add and to support what Jennifer and Yolanda have said, even though I said the number of nurses are going up, that does not mean we have enough. And so we need students to be in these programs and come out of there. Study was done by Lassner and Linda Aiken's team along with NCSBN right before the pandemic. And we found out that nurses in Illinois and New York, which we surveyed, were very, very stressed. They were short-staffed beginning then. And now the pandemic has hit. So schools play a huge role in this as much as the hospitals.
Thank you.
On to the next question, there is one more point that I would like to add. We also too, in the nursing workforce, have to be resilient in ensuring that we are supporting the mental health of our nurse workforce. So we need to tap into our federal government, whether that is the Health and Human Services to support scholarships and grants and funding to support our mental health for our nurses. We need to ensure that there are ways that our nurses can report that they are having issues in a private, confidential way without that being frowned upon, and having a safe place to go and support their treatment and care.
Yeah, I think the other thing that I would add too is there is a lot of opportunity when you look at retirement. We have been able to really, with our virtual ICU nurses, we have nurses who worked in the ICU setting for 30 years, but now physically are not able to do that work anymore, but they can come work in the command center and provide that very valuable knowledge. We do virtual ICU in small critical access hospitals across the state that a lot of those nurses on the night shift are brand new coming out of school. And so able to have that nurse in the command center that is supporting them and being able to be available to them. So it is a great opportunity in this time of staffing crisis when we look at burnout and resiliency. The world of digital nursing is really an opportunity for those nurses that are not physically able to be out in their setting, but they are definitely still want to care for patients.
Okay, thank you. Okay, regarding the future of nursing 2020 to 2030, charting a path to achieve health equity, what are your thoughts about building collaborative practice models and how does nursing play into these models? Yolanda, would you like to start that?
Items that I mentioned earlier, we do need to ensure that our advanced nurse providers are practicing to their full scope. So we need to put in initiatives and policies that in order that they're doing that, and that will also help with access to care. We also need to ensure that we have support through funding. We need to ensure that we can get underrepresented students into colleges of nursing. We need to ensure that we support our communities through funding, access to care. There is so much that we need to really be involved in policy making. So we need to ensure that our politicians hear our voice in healthcare from the front line, from the leaders that are doing this every day. And there's not assumptions of what we do, but we can speak to what we do so that we can ensure that healthcare is improving, not only for us in the workforce, but for the community as a whole. And it's very imperative that we stay on top of these issues. And health equity is a very important issue. For those of us in the Chicago area, we know that we have a health disparate population in a good majority of some of our hospitals. And we need to ensure that we are ensuring that these patients are getting the care that they need and the fair care and treatment. What does that look like in the future for Medicaid and Medicare? You know, the funding is proposed to be decreased. How are these patients going to be served in the future? So we need to stand up, we need to do research, more research in these areas. We need to ensure that the underserved population are also involved in research. So there's a lot for us to do as we move forward in 2020.
Mhm. Thank you. Jennifer, do you want to add something?
Yeah, I would like to. So when I think about health equity and I represent downstate Illinois and really the rural population. And we know that there is a lot of, in rural communities, there is a lot of really underserved areas that do not have healthcare at all. And so we, in the last year, have really been focused on innovation. When you think about truly transforming care and making it equitable, we have to use innovation. We have to think differently because the way we have been doing it is not getting us where we need the outcomes that we really want for the communities that we serve. We are very fortunate to be granted some Medicaid transformation dollars here recently in partnership with 4 of our federally qualified health centers in our rural communities to really look at how we use digital care and remote patient monitoring to focus on Medicaid patients and the engagement of them with health literacy, with chronic disease management, with maternal fetal. How can we use remote patient monitoring with a combination of digital applications to keep them engaged in their care throughout their pregnancy and postpartum, as well as then for those sickest of our sick Medicaid patients, how do we wrap around service for them 24/7 so they're using the appropriate level of care, because we know that a lot of times the only thing that is available at 2 a.m. is our emergency departments, and that is not the best level of care most of the time for our patients. So I think my plea for everyone and all of our nurses is to really think differently and to be really transformational. We're going to have to use innovation. And I think a lot of times people think that telehealth or digital care is technology. And that is such a small piece of it. It is really about care. That's why I am insistent that it's called digital care, because we cannot take care out of that. And nurses are a key component of it.
Thank you. Okay, one more point.
And
please.
oftentimes we put emphasis in our acute care models, the ICU, the ED, especially when we're in a pandemic, because we do need those nurses in those areas on the front line. We also need to ensure that we have dollars in education spent towards care management. The care of the patient through the continuum is very important. That helps to ensure that we also have the patients going to their primary visits on a regular basis and not the ED as their primary care. When we support funding in the care management and ensure that we get more case managers and utilization managers in our hospital settings, that will help us to work with the patient on the primary care model with access and continuum of care. So that's also important too.
Okay, thank you. Okay, this next question is for Maryann. Can you tell us about some recent changes to the Nclex exam and what prompted them? Oh.
First of all, I need to provide a disclaimer here. I don't work in that division of the organization. It's split in two, and I am in charge of the regulation part. So, but I do know something about it. And,
Good.
you know, one of the things that prompted, there were a couple things that prompted the change. Number one is in the early 2000s, there was a lot of literature coming out about critical thinking. And at the same time, there was also some studies. Pat Benner did a study that showed new graduates make a lot of errors in critical thinking during their first year of practice. And so there was more and more an emphasis on critical thinking, and NCSBN started to ask, well, are we sure that the Nclex measures that? And in addition, we do every 3 years, we do a practice analysis. And this is really the way the questions are formulated for the Nclex, is we look at all the things and all the responsibilities and the knowledge that nurses need to know. And we find out new graduates in their first year, what they're doing frequently, and how important it is. And what we were seeing was this huge trend in critical thinking and clinical decision-making, and the fact that patients were becoming much more acute care. And so they began thinking about how they reshape the exam to capture some of that knowledge and ensure that nurses have minimal knowledge in clinical decision-making. And what they're doing is it will only be a portion of the exam, but it will be case studies. They're trying to mimic something that could really occur in a clinical setting, and the questions will be branching. They will build off of one another. And some of the option choices, the types of item types, are going to be a little bit different. And some of them, a student or new graduate could actually get partial credit for. So if they take maybe not the best answer, but an answer, well, maybe not so bad and certainly would not harm the patient, they can get some partial credit for that.
Okay, thank you. Okay, what changes in innovation do you see on the horizon that you believe will impact the nursing field? And how can alumni help in the wave of change? Jennifer?
Well, I could talk all day about this, and I think I've given a lot of examples already. I would just also maybe share another example of a new care delivery model that some of you may have heard of, is an acute digital hospital at home. So this is really taking care of acute patients in their home. Mayo's been a leader in this, Kaiser shortly behind. We just started our program, and when I think of programs like this, it really is a brand new skill set for our nurses. So these are nurses that are not home care nurses, and they're not acute care nurses. They're really a didactic blend of the two that we need to make sure that we have simulation training, and really it will become really a new specialty as we look at some of these different kinds of nursing that we need in the workforce going forward as we change our models of care. So thinking about having a command center that monitors the patient at home, but then we also have those nurses that are boots on the ground that are going in and rounding on those patients. And from Maryann's standpoint, really thinking about how this impacts our regulatory, how it impacts our rules and regs and compliance. Those don't change as fast as our care delivery models have changed in the last year and a half, as we have looked at COVID and really said, these are new models that are here to stay and can really impact the outcomes of our patients. So I think the innovation is, there's no shortfall of innovation right now, but there is a balance between our regulatory requirements, our licensure, our scope of practice, that we have to continue to make sure that we are looking at those two things in parallel, because transformation and innovation is on the fast train. I used to think it was on a plane, and now I think it's on a rocket ship. I used to say I was building the plane while I was flying it in this new space. And now I know that it's built, but it's now a rocket ship trying to see how far it can go and how fast.
Mhm. Thank you. All right, any other thoughts from either of you? Then we'll go to the last question for all our panelists. What advice do you have for future nurse leaders? Anyone want to take this first?
Well, I guess I could. Number one, we need to ensure that nurses are basing their practice on science and evidence-based practice. Because obviously right now we know that I'm sure there are no UIC nurses, but there are some nurses that are not practicing based on science, and they're giving out a lot of misleading propaganda. Number two, nurses need to get involved in policy. We need nurses at the table, from the table at the state and national capital and the Capitol in Washington, to that even of the nursing, the board of nursing. We need good nurses to serve in regulation. And I guess, that I would say one last bit of advice for future nurse leaders: get a PhD. I got mine here at UIC, and I have to say, I owe a lot to everyone here and all the mentors and faculty that I had.
Yay. Good. Yolanda.
My advice would be to continue to learn. Although I have a PhD and several certifications, I'm always learning. Also, obtain a mentor. No matter what level you are in your career, you need a mentor to advise you, to guide you, to help support you. Healthcare these days are very challenging. So you need someone to speak things through. There are people sitting at the table here that I'm on other committees with, and we're also CNOs in different hospitals, but we can help each other. Also, I think it's very important to be, as she said, and I've said earlier, we have to be involved in policy. We need nurses on boards, whether it's a healthcare board or a nursing board, we need nurses on board. So that's very important, and that should be in our future also. So that would be my advice to any future nurse, and also nurses that are currently practicing that have been in the field for a while.
Jennifer?
My advice for future nurse leaders is the sky's the limit. You can really do anything you want, and you can bring that nursing core to everything that you do. I would have never thought when I obtained my bachelor's and master's from University of Illinois, Chicago in nursing administration, that I would be working with Google and Amazon and startup companies and big tech companies to care for patients. So you can do whatever you want, and that core nursing foundation really allows you to keep the patient at the center of everything.
Okay, thank you all. That was really very good. Let's give a round of applause to our It was thought-provoking, interesting, and informative, and so relevant to our current understanding. And now I guess, Sarah, we're going to open it up for Zoom questions or any questions in the room. Are there any?
I will run a handheld mic to anyone who raises their hand.
And those of you on Zoom, you can type your questions in chat and we'll get them to the panelists in turn.
Hi, that worked. Good morning. A comment and a question. Just a comment about compact. I would remind people, it really is a state issue, involves our state legislators. And developing relationships with collective bargaining folks, since they are the ones who have the greatest concerns. But my other question, or my question, has to do with faculty. And I keep wondering if we have any creative approaches about recruiting faculty. All I've ever heard of is to provide scholarships or grants so that they can get their graduate degrees, or what, ways to pay back. That's fine. They do something similar in the National Health Service Corps. But the biggest problem with that is once people kind of pay their dues and they are at institutions for 3 or 4 years, they tend to go elsewhere. Certainly salaries are an issue. That's always an issue in any problem industry. I just wonder if anyone else if there are any creative ideas, and actually maybe even among the group. I mean, I don't know that we've really examined or studied faculty as much as we have in terms of students, and what keeps people from becoming faculty. And I do think a lot of it is money. Clinical practice is very lucrative now, which is wonderful. I mean, long overdue. But there are probably other issues too. So just food for thought. Let's do some more study about that, because they keep opening BSN programs and APN programs, and there are not faculty to support all these programs that have been opened and accredited.
Mm-hmm. Dale? Microphone here. Who? Oh.
Good morning.
There. Wait just a minute. We have somebody
Sure,
else here.
Go ahead.
Well, Dale, are you going to comment?
Go ahead. Yeah.
I just was going to echo I think your comments are really well suited. And I wonder, I think we've done some work with practice and academia working together to help solve some of these problems. I think we need to work in a greater way with that. I sit in an organization, we're sitting in the national database for nursing quality indicators with 99% of our nurses with master's and doctor's degree in the NDQI database. Yet we don't really connect with academia in the way that I think we could help solve some of the faculty issues in terms of how could practice help with the salary issues, and also create a pipeline for faculty in a much more creative, innovative way than what we've done in the past. So I think there's tremendous opportunity there, but I don't think we're going to be able to solve it in isolation. It's going to be through partnership.
Mm-hmm. Okay. Was there another question? Mm-hmm.
Yes. Good morning. My name is Monique Lewis, and I'm a traveler nurse. I'm a case manager. Maryann, this is for you, because this is what I've been hearing from nurses within, the Chicagoland area and on a recent assignment. And that is nurses being directed by non-clinical people in regards to how they practice nursing. And what is state boards around the country doing about a non-clinical person directing nurse practitioners, nurses in clinical and in acute hospital settings?
I don't know, because I have not heard that as being a significant problem nationally. But I think, are they just managing them, or are they, you say they're directing them as to what they can do in terms of scope of practice?
Yes, ma'am.
You know, that could be something that is dealt with by the state board, because nobody can tell a nurse to do anything that exceeds her scope of practice, his or her scope of practice. And obviously, the nurse is held accountable for what they do. And so even if somebody tells them, do surgery on that patient, I'm telling you that right now, this is an ethical issue that a nurse cannot just do something because she's told to do that. And so, you know, that is something that there needs to be probably some intervention, but I would need to know a little bit more about the case, and maybe I can talk to you later.
Okay. Second question is for, about nursing leadership. What I'm hearing from nurses is that nurse leaders, from nurses on the floor who are providing direct patient care, they're saying nursing leadership does not have their back. They're more in line with the corporate executives who are non-clinical people who have a business degree from Yale, Harvard, Princeton, or whatever. And they don't feel that nursing leadership has their best interest at heart. What are we going to do to overturn that and, have nurse leaders, more involved and more engaging with the nurses on the floor who are providing direct patient care?
I try to lead by example. I think my nursing team, they have exemplified to me and told me that I really am a nurse's nurse and I advocate for them. So when I go to different committees or on ANA Illinois, or I find out different things that are happening to the state, I bring them back. I have a CNO forum where I discuss all of these things. Most recently, when we had SB 2153, the Nurse Care Committee, I went back to them, I explained all that to them, what it means to them, how I could support them through that. And it's really something for them, not for me as their CNO, but it's helping to support their direct patient care practices and ensuring that we do have safe staffing practices. And if someone at any time feels that we don't, how can we sit down at the table and not let the leaders lead the discussion, but let the direct care nurses lead that discussion and how we can solve those issues? As leaders, we do need to ensure that our teams understand what's going on globally, federally, nationally, and help them support. We do have budgets and things like that that we do have to adhere to, but there are numerous ways that we can show our support to our team and ensure that we have their best interests in mind, because their outcome is also my outcome. And I want to ensure that we have the best patient outcomes and we're practicing to the full scope of our license and we're striving for nursing excellence at all times.
So I can maybe address that a little bit from my perspective as well. So as the Senior Vice President of our digital health entity, we have over 400 nurses that report up through that entity. And we have a Chief Nursing Officer as well as a Chief Medical Officer. So our Chief Nursing Officer in our digital health entity has really brought together our digital health nurses in a way that they have never been before, because they have not necessarily been recognized as their own team of nurses. They have been, either within the hospital setting or within the ambulatory setting. So really setting the foundation with professional practice, making sure that we have nursing peer review, making sure that we are involving them in key decision makings, making sure we have evidence-based practice. And a lot of our programs, we are creating that because it does not exist today. So really looking at what are those nursing quality indicators for our digital health nurses that we can't benchmark anywhere at this time, trying to create that and helping them be involved in research as well. So I think giving a voice and making sure that we are professionally developing all of our nurses from frontline to our nurse leaders, and that you have really strong chief nursing officers that support that, like Yolanda. Certainly I just met her today, but I can tell that she is a huge advocate for her nurses.
Okay, thank you. Are there any questions on Zoom? Who's monitoring that?
Not yet, Sabina.
Not
So,
yet?
and anyone else in the room that has
Okay.
questions or comments for our panelists?
No? If not.
Yeah, no, those aren't questions. Yeah, those were comments from earlier, but okay.
Okay,
Oh, Dale.
okay.
I'm going to ask Yolanda this question because we had the opportunity, I had the good fortune of working with Yolanda in my career. And I would say, the question I have for you, Yolanda, is what have you learned from the time we worked together to the time that you're in this chief nursing role that you think would be helpful for the group to know?
Thank you, Dale. Dale was a previous boss and he's also a mentor, and he's kind of seen me through my trajectory, my career. So one of the things that I have learned is that you do have to stay involved. You do have to get on committees. You do have to keep learning. As I keep learning, I can bring back those things to my staff and team, what I'm learning. Also, as I said, the mentor piece is huge because when I was at UIC with Dale, we had conversations. He knew that my trajectory when I was a director is to be a chief nursing officer. At that time, I already had my PhD here and I was a critical care director. So we would talk through some things on how that looks and what that trajectory will look like. He, as a mentor, guided me. Most of my career at that point was in the academic hospital setting. He said, Yolanda, you need to get that community health hospital experience. And that catapulted my career, I would say, after I did that. I'm always willing to go to policies. When we have lobby day in Springfield, I go down and talk to our leaders there so I can have an understanding what policies look like and what I can take back, not just to my team, but other boards and all across Illinois for nursing. I think it's very imperative to be involved and stay involved and to continue learning. And I can't say this enough to have that mentor to help you. And then because someone like Dale has helped me, I help others now. I know what that looks like and I role model in each step of the way, whether I'm doing something in my community service as a nurse, in my church or community or with the police department, whatever I may be doing, or if I'm teaching, I'm role modeling so people can understand that there's so much to nursing. We're not in a box. We should never not have a job because there's so much to do in nursing. My nurses always say that you advocate for us. You're a nurse's nurse, and I'm passionate about it. I have something on my winter card. I have peace, love, nursing. That's how much I love nursing. I drive around with it, so I would just encourage others to do what you're passionate about. Leadership and education is something that I'm passionate about. So I would say, follow your path. I spoke on that path earlier on in my career and I kept going on that path. And I would encourage others to follow your passion.
Okay, thank you very much. I think that concludes our oh, is there one more question there? Sorry, I didn't see the hand.
First of all, I want to thank the panelists for their work on innovation. Being in the front line of public health this year has been extremely challenging. And one of the questions I asked is, how are you preparing the next generation of nurses really for interprofessional practice? We've seen many times these may not be the same level of licensure that we're familiar with in the inpatient or our traditional medical settings. I think about my nurses having to work side by side with units of the National Guard for vaccine administration. So can you speak to a little bit about that and how you see that progressing? Because I think that that's another trend we're going to see as we move through these kinds of pandemics and other kinds of issues.
Who wants to take that question? Jennifer?
I can just start because Sandra and I know each other from some work that we've done in the Region 1 with an IDPH grant of pandemic navigators. So really connecting those with COVID-19 and a lack of resources with resources within their own communities. And so really looking at, I think, one of the key things that I've seen is just that community health worker, digitally enabled is what we're calling them from our standpoint, but how nursing can really be a key component of those really non-licensed lay community members, but that their clinical needs are escalated to nursing. And that's a whole different realm of nursing than being in an acute care setting, even being in the public health setting, but really overseeing a large geography of lay community health workers that are providing digital applications in my world, in digital applications that then can be monitored from a centralized standpoint. So I think that a lot of work that we have to do is really thinking about how we utilize and collaborate with non-traditional, non-nursing community members. We have a faith-based nursing program. We have technology vans. We have caravans. And nurses play such a key component on those teams of being able to be a part of that care delivery team.
Well, any other comments? Because we need to conclude. Yolanda, go ahead.
My organization is doing something interprofessionally. We have the standard succession planning, but we also have it where a nurse can be mentored by someone other than nursing. So we've set up a program where a bedside frontline nurse can go and be mentored by the director of pharmacy. So then they can have an understanding of the full scope of leadership in the organization outside of nursing. So those are some of the things that we're doing within my organization.
Thank you. Wow. This has been a terrific panel today, and enormous thanks to Maryann Alexander, Yolanda Coleman, and Jennifer Junis. Let's give them a big round of applause.